Hello friends, welcome back. In the previous lesson, we had a brief overview of narrative medicine, and that prepares us for this lesson, which will deal with the medical interview. A medical interview is going to prepare you to establish a new relationship with your patient. For this, you will be investing in intuition, empathy, detecting emotions, and developing these skills so that you are drawn closer to your patient. On a number of occasions, doctors have found that they themselves resonate the emotions of the patient. In the supplementary reading section, you will find a lot of references and also documents so that you can expand your knowledge in that direction. Illness is actually a biopsychosocial phenomenon. You must understand that illness, disease, and sickness are three different terms. Illness is the experience that a person is undergoing, and illness is what brings the person to the doctor. Illness consists of discomforts, some symptoms, or a desire to get better or fitter. The moment a person steps into a doctor's office, the doctor gets busy with discovering a disease. A disease is viewed as an entity and having its own existence, which is a faulty view. No doubt we require tools such as radiological examinations, blood work, etc. to find out what is the cause of the illness. But our efforts should not be restricted only to that. We must go into the origin, which lies in biology, psychology, and the social environment of the person who has come to you to seek help. I'll just take a moment to go to the third term which I mentioned earlier, which is sickness. Sickness is entirely the social impact on the person. Social distancing, quarantines, all these things are part of sickness. They do not constitute disease, and far less do they have anything to do with illness. So we just saw that this is the cycle that brings the patient to the doctor. And we must understand each of these spheres closely. Did you know that while the patient is telling his story, how often is the patient's narrative interrupted? They conducted a study by recording interviews of a number of practitioners. And what they found was, and this is the report, you can always refer to it later, and they found that the patient's narrative was interrupted on an average every 11 seconds. Doctors seldom listen. That's what they found. They interrupt the patients too often. As I told you, the median value of interruption time was 11 seconds. Specialists, in fact, interrupt even more. They don't have the time to listen to so-called small talk. And all that ends up reducing the chances of care and as a consequence reduces the chances of cure. So your very first interview will set the tone of the prognosis of the patient. There is a three-function approach which has been summarized in this book by Stephen Cole and Julian Bird, and I would recommend you to go through it or at least pay attention to what I'm just about to tell you. The three-function approach is all about the medical interview. Those three functions are: function number one is to build the relationship about which we talked earlier. Function two is to assess and understand the patient's problem. A person who comes to the doctor, say for a pain in the knee, is not just what the X-ray tells you about. It's much more. It's the impact that the knee pain is having on that person's life. That person's life includes his family life, his professional life, his earning capacity. So you must try to understand it from the patient's perspective. And function 3 of the medical interview is to collaborate for management. The current approach is, after making all the interruptions every 11 seconds and keeping his head down and looking into the reports rather than facing the patient, the doctor comes to a conclusion and he scribbles a prescription and hands it over to the patient. The patient goes outside the office and he is explained how the medicine is to be taken by the pharmacist. That has to change if I have to bring about a change in the care of the patient and the cure of the patient. And this is the foundation on which homeopathy is built. We'll go into a little detail of the 3 functions that we just mentioned. Function 1, if you will recall, is about building a relationship. The first essential thing is rapport, paying attention to the emotional domain of the patient. What that requires is your response. The patient is watching your eyes and the expression on your face and your posture. If you are bending over to listen to the patient, if you have concern in your eyes, you will establish rapport. Also, you'll have to pay attention to the illness experience, the experience of pain, of disability, and the accompanying emotions. But you'll be surprised that the quality of the pain has got very little value when it comes to allopathic practice. If somebody says it feels like somebody is stabbing me in my back, that is the quality of pain, do you think it's going to affect your choice of medicines? But it does when it comes to homeopathic practice. The way a person relates that story and the emotional energy of that dialogue will direct you to a homeopathic remedy, which otherwise would be worthless if you were limiting yourself to allopathy. Also, every illness comes with anxiety, sadness, depression, anger, etc. And it will pay big dividends if you pay attention to that and make a note of all those things. These feelings could be because of insecurity, job loss, family commitments, fear, etc. And finally, the good news is that this particular methodology has shown improved outcomes in hypertension, diabetes, and arthritis when they did studies based on evidence-based medicine methodology. The second function is to assess and understand the patient's problems, not what is shown in the reports and not what is found in the physical examination. The conversation is the most important part of your encounter, and its value is much more than the reports or physical examination. 3/4 or 75% of all information is gathered by listening. Did you know that 77% of the times physicians do not fully understand the reason for the patient's visit? And they are not to blame. They are seeing so many patients, they are burdened by a system, they have to keep records and so many other things. And besides, they have their own personal life and the emotional baggage that they carry with that. You must try to understand the patient's explanatory model for illness or symptoms. In every case, you'll find generally the patient in the first encounter will tell you that, doctor, I think this is the reason. And we try to reason with them scientifically and prove them wrong. And that's where the rapport is finished. Have respect for the patient's view of the disease. In fact, William Osler, the father of modern medicine, used to say that diagnosis is what the patient tells you. It's not what you diagnose on the basis of any standard protocol or a DSM or any such thing. And you must also find out, make a note of, and realize the impact that the illness has on the quality of life. You can only claim that the person has been cured or that he's gone through a successful treatment if the patient reports that the impact of the illness has been reversed. The quality of life has improved. Your tests are not going to say that the patient being symptom free is not the answer to the patient's turning to you for help. The third function is to collaborate for management. Educate the patient for a shared decision making. This is very important. Instead of blaming the patient for his disease. For example, if you had not smoked for 25 years, you wouldn't be seeing me for your lung cancer. When in doubt, just check it out. That is very important. If you find that the patient or the expression on the face of the patient shows some doubt or lack of clarity, repeat your instructions. That is what is meant by collaborating for management. As you go along with your case taking, summarize the points. Also, at the end of your case taking, just go through all the points. That is the opportunity for you to ask questions, not when the patient is narrating his or her story. You should reserve your questions after he has stopped or she has stopped to finish the story. And this will reassure your patient that you are really interested in getting all the facts in order. Another thing is your questions should be open-ended and not suggestive questions. Because when you make a question which is like a multiple choice question, you are limiting the response of the patient. In fact, sometimes doctors ask questions which either have a yes or no as an answer. I'm sure you know all this, but this is just a review of your old knowledge to remind you how important it is when you are doing the medical interview, especially the first interview that you have with the patient. Of course, the same rules apply when they visit you for follow-up. These are three simple words. Tell me more. Or you can say, could you tell me more so that I could help? Because patients come to you for help. That is one thing you must always bear in mind. You have that noble opportunity of helping a person, getting his or her life back to normal, so that they can pursue their passions, their happiness, and the joys in life that come with a fulfilled life. So that brings us to the end of this lesson. Thank you very much for your attention. And I wish you a bye-bye till we meet again in the next lesson. Thank you.